Hello, everyone. Good morning, good afternoon, and good evening. Welcome to today's webinar conducted by ASPA Paediatric Cardiac Special Interest Group. Today, we are going to talk about the usage of NIRS in cardiac surgery from a pediatric perspective. Pediatric cardiac surgery presents unique challenges, and the use of NIRS has emerged as an invaluable tool in monitoring cerebral and systemic oxygenation. By providing real-time, non-invasive data, allows clinicians to make informed decisions that directly impact the well-being of pediatric patients undergoing complex cardiac procedures. Throughout this webinar, we are fortunate to be joined by a distinguished group of very special experts who will share their knowledge and experience on how NIRS is enhancing outcomes in cardiac surgery. First of all, I want to introduce myself. I am Dr. Dilek Altun from Acıbadem University from Istanbul, Turkey. I am a pediatric anesthetist, and my interests are adult and pediatric cardiac anesthesia and intensive care unit, pain management, difficult airway management, and difficult vascular access. Today, Dr. To will be together with us in the moderating of this webinar. Dr. To from Vietnam works as a pediatric cardiac anesthesiologist in Hanoi Children's Hospital. Her interests are pediatric cardiac anesthesia, lung ultrasound, protective lung strategy in minimally invasive cardiac surgery.
Dr. Tao, your audio is not flowing. We cannot hear you. We cannot hear you.
How about now?
Yes, we can hear you now.
Can you hear me now?
Yes.
Okay, sorry about the problem. So we are the Cardiac SIG, and we have the vision to create a collaborative platform for the sharing the expertise dedicated to advancing the standard of pediatric care in the region. So today we will have 3 lectures from prestigious speakers with I think we will know a lot about one of the non-invasive and very versatile tool like NIRS, using in the neonate, in the pediatric cardiac surgery, and integrated into the goal-directed therapy. And something about the house rule. We are in the webinar base, so you can see that the chat and raise hand function are disabled. So if you have the question, please send your question or comment via the Q&A function. And we, as moderator, will highlight your question to the appropriate speaker during panel discussion. And some questions will be answered as text by appropriate speaker in the Q&A box, so you can check it. We also do the polling before the lecture. When the poll is launched, you should probably answer the poll question within 30 seconds, and we will send the results soon after we end the poll. And after the result is shared, you can close the poll so that you can see the full screen. We also provide the certificate of attendance. The post-webinar survey will be sent to your email tomorrow, the 17th March at 5 p.m. A certificate of attendance will be forwarded to those who successfully submitted to the post-webinar survey. So please ensure that you have correctly entered your full name and your email address. We available in 3 platforms in the website aspa2000.com, on Facebook and YouTube. So please visit, like, and follow us. So we will start with the poll number 1. The NIRS measure blood in venous, arterial, and capillary space. what is the relative percent contribution to the final mixed benefit? You have 30 seconds. Wow, we have quite different perspective of answer, and you can see here 54% choose the correct, and very close to this is 43% choose the wrong one. The poll number 2, a 4-week-old infant undergoing a procedure, a NIRS monitor is placed. Cerebral saturation is 70%. The patient is intubated and placed on the volume target ventilation, but the tidal volume is accidentally set at 10, causing over-ventilation. So 15 minutes later, what the value should you expect the NIRS? It should be 95%, 80%, unchanged, or 50%. Wow, we have full range of answer, and the correct answer is, you can see that, but it accounts for just 21%. So I think we will have the lecture with those, and I think that it can help you to understand the reason why the answer of those poll questions.
Thank you, Dr. Tao. As Dr. Tao has mentioned, we will see the correct answers in the lecture of Dr. Vasilius. I want to introduce our first speaker, Dr. Zachary Vasilius, Assistant Professor in the Department of Pediatrics at Washington University. He is also the co-director of the Neonatal Intensive Care Unit Program at St. Louis Children's Hospital and director of the Neonatal Neurology and Physiology Research Lab. His interests are investigates brain injury mechanisms and advances neuroprotection strategies, integrates real-time neuromonitoring, clinical data, and neuroimaging to identify injury risk signatures and improve outcomes for critically ill infants through advanced machine learning. Now we will listen to the lecture of Dr. Vasilius. If you have any questions, he will answer them in the Q&A session.
Hi there, my name is Zach Vasilius. I'm a neonatologist at Washington University in St. Louis and at St. Louis Children's Hospital. I'm really honored by the opportunity to speak to you today. I'm going to go through a few concepts of near-infrared spectroscopy, a really exciting technology for helping us to really understand oxygenation levels in the brain of neonates and how that helps us to improve the care of these babies. So these are some objectives that I'm planning to cover today. I'm going to start just with a basic introduction to NIRS, recognizing that people have different familiarity levels with this technology and just trying to get everyone on the same page. I'm going to talk about how it's been used clinically, what normal values are. I'm going to review some recent clinical research, particularly a focus on silent hypoxia, where these monitors help us pick up moments in time where brain oxygen levels are really low, and none of the other monitoring technologies we use show us that there's a problem. I have a few case studies that I'd like to share, and then a potential guideline for application. And then, although there won't be time for question and answers because this is pre-recorded, I'm more than happy to answer any questions via email that anyone has. So what is NIRS? So this technology, in some ways, is like a pulse oximeter. It uses light to measure oxygen levels in tissue. Now, it's a little bit different than a pulse ox because the light doesn't pass through the skin to be detected on the other side of the probe, but it rather moves in a curved shape. So as you can see from the picture on the right here, red and infrared light go into through the skull, through the skin, down into the brain, and then the light is scattered. So some of it is scattered, some of it is reflected, some of it is absorbed, and some of it returns back to the sensor. Now, depending on how much oxy and deoxyhemoglobin you have, different amounts of red and infrared light are absorbed. Deoxyhemoglobin absorbs more red light, oxyhemoglobin absorbs more near-infrared light. And so by using multiple wavelengths of light and calculating this ratio, we can estimate how much oxy and deoxyhemoglobin are present, which is really just what a saturation is. Now, NIRS is also different from pulse oximetry in a very important way, is that it's venous weighted. It looks at blood in the entire space that the light is passing through. It's not limited just to the arteries like a pulse ox is. And since most of our blood is in the venous space, about 70% at any given time, this is a venous weighted measure. And you can really think of it as a very close approximation of mixed venous saturation. Now, the sample probe that's shown in the picture here has 2 detectors. That's fairly common in commercial units. And that sensor that's closer to where the light is coming out is really designed to pick up blood flow that's in the scalp and remove it from the signal, because we're not interested in scalp blood flow. We're interested in brain blood flow. These are just some examples of 2 different NIRS monitors that are available on the market. They're all, regardless of the manufacturer, they're all fairly similar. They have a display unit that can display the value of typically up to 4 different channels, and the sensors that connect the device to the patient. They usually have a graphical display that shows what the saturations have been in the preceding 1 to 4 hours as well. So where can you put NIRS probes? The most common use in general, and especially in neonates, is the brain. And you can put it bilaterally. You can put it on the right and the left. Or you can put it just on one side. In general, the rule of thumb is to avoid putting it exactly midline, because there's the venous sinus right there that could potentially alter the numbers, although I don't think many people have actually seen that be true in practice. The probes are fairly large, so sometimes there's a little bit of creativity that's involved in getting the spacing, particularly if the baby's on bubble CPAP and you're trying to get the CPAP hat in there and still have enough room left over for the NIRS probes. We strongly encourage the use of Mepitel or some other skin barrier that you apply first to the skin, particularly for preterm infants. You can also do monitoring of the abdomen, the splanchnic bed. We typically do this by just tucking the probe in the diaper, and you can put it on the right or the left side. And then you can also do renal monitoring that you do on the right or left flank. And the Invos monitor, as is true for other NIRS monitors, supports up to 4 channels. So you could do 2 renal, 2 cerebral, a splanchnic, any combination. So I mentioned this earlier, NIRS and pulse oximetry have a lot of things in common. They both use red and infrared light. They are both measuring oxygenation, and they're both non-invasive, but there are definite differences. So pulse oximetry is transmission-based. The light has to pass through the tissue and get to the other side. NIRS is reflectance-based. That light has to bounce off of something and come back to the sensor. Pulse oximetry is only arterial saturation. NIRS, because it is mixed venous saturation, it actually gives us a measure of oxygen delivery and consumption, all in a single number, and it is very localized. It is the measure that goes just to the part that you have applied the probe to. These differences mean that we use it differently. In a pulse oximeter, if it's low, then that means we just need to turn up the amount of oxygen we're giving, and if it's too high, that means we just need to turn it down. With NIRS, if your RSO2, which is the abbreviation for regional oxygenation, if the number is too high, it could mean, just like a pulse ox, that we're giving too much oxygen. That is absolutely true. But it could also mean that the tissue we have it applied to isn't extracting oxygen as much as it should be. And then the same thing, if it's too low, is either not enough supplemental oxygen or that tissue is sick and it's extracting more oxygen than would typically be expected. And so NIRS monitor should make us think a little bit about what we do with it. So we could do lots of things with it. This is an example of what a NIRS recording over a long period of time looks like. And you can see it moves around just like a pulse ox does. But we can use it to measure oxygen delivery to the brain. We can use it to measure cerebral autoregulation, the efficacy of treatments, both giving us an indication that we need to do something for the patient and the response to treatment, early warning, and then NIRS-guided interventions. So let's start with what is normal. We are fortunate in neonatology to have had a number of large reference studies that have been done to guide us. The plot on the left is from Gerhard Pichler in Europe, who studied NIRS in the delivery room right after birth. And NIRS follows the exact same pattern that pulse oximetry does. It starts low, it rapidly rises over the first 10 minutes or so before becoming stable at right around 70%. The panel in the middle is a study that was done in the Netherlands by Thomas Alder-Leesten, where they studied 1,000 very low birth weight babies and came up with a median value in the first 3 days after birth of about 65%, with this 95% confidence interval of 55 to 85%. Those ranges are something you hear very commonly in neonatology, but I think it's really important to note that the values of that are generated by a NIRS machine depend on both the probe that you are using as well as the monitor you are using. So if you use the small adult sensor, for example, with the INVOS monitor, and then you switch it for the neonatal probe, still with the exact same INVOS monitor, you'll get slightly different numbers just because of the design of the devices. There are papers out there that you can use to adjust the values so that you're working with the same numbers. This Alder-Leesten study in the middle here, they use the small adult sensor for that one. So if you adjust it, the actual expected range using the neonatal sensor is really 63 to 93% rather than 55 to 85%. And then over on the right is HIE, which has a very different pattern. These babies start off with relatively normal cerebral saturations, and then they become very, very high after about the first 24 hours, 24 to 36 hours. And this is largely a function of our treatment for these patients. Many babies with HIE undergo hypothermia treatment, and the whole goal of hypothermia is to reduce metabolism. And that's what we're seeing here. We have effectively reduced metabolism, and the brain is not extracting much oxygen. So that is, although that is a very high number and a little concerning at first glance, it's actually a reassuring sign that our treatment is working the way we want. So all of this really should be focused on hypoxia. What causes cerebral hypoxia? And the brain itself is a very expensive organ. It uses a lot of our cardiac output. Almost a quarter of what our heart generates goes directly to our brain. And when our brain is sick or injured, it uses even more oxygen. And part of our role in providing critical care to these patients is to make sure that we maintain this nice balance. This is a children's playground game of seesaw, and we'd like it to be perfectly balanced between the two sides. So on the one hand, the supply is all driven by oxygen carrying capacity, systemic oxygenation, and cardiac output. And there's demands placed both by typical brain activity, just its normal function. Seizures certainly drive a lot of demand. Injury is another big demand generator. And then growth. We are taking care of patients that are rapidly growing. They need more blood flow than an adult, for example, just to maintain this growth. And so if we're not careful about maintaining this supply and demand, we run the risk of hypoxia. Also potentially hyperoxia, but that's less common in babies. So we'll start with the most straightforward concept of this, fractional tissue oxygen extraction. And this is just the percentage of the oxygen that's being delivered that is being extracted by the patient. And all you need to do this is a pulse oximeter. So in this case, the saturations are 95% for this patient, and their cerebral NIRS are 66%. And you subtract the two of them and divide it by the pulse ox, and in this case, you get an FTOE of 0.305, which you could round up to 31. So this patient is extracting 30% of the oxygen that is being delivered, their brain is, which should be about 20% normally. So this is a patient that is experiencing increased cerebral oxygen consumption compared to normal. This paper on the right here shows how chorioamnionitis, a common condition faced by many of our patients, drives increased oxygen extraction, likely because of inflammation and infection. Anemia is another potential factor. This study was done by Helena Whitehead, who's one of our junior faculty members, where she studied very low birth weight babies and did repeated weekly NIRS monitoring, cerebral NIRS monitoring, looking at the hemoglobin that was measured on a blood test, and found that as the hemoglobin gets lower and lower and lower, cerebral saturations drop with it. And, not surprisingly, oxygen extraction increases. There's a very nice linear relationship there. And that's because we're delivering less oxygen. The more anemic you are, the less effective your oxygen carrying capacity is. And that is clearly affecting the brain. IVH, intraventricular hemorrhage, is another factor that can alter cerebral oxygenation. And from studies that have been published, it appears that there's really a two-phase process here. First is hyperoxia. There are a couple of studies that have shown this increased sudden rise in cerebral saturations, likely around the time of the hemorrhage. This probably reflects impaired autoregulation and injured tissue that's not extracting oxygen. It's a decreased utilization. And then after that, there's a relative hypoxia. The saturations are lower, probably from increased demand responding to that injury. And in fact, when we looked at this in almost 200 babies going out for the entire NICU stay, we found two things. So first, every single patient, regardless of their IVH status, has a drop in their cerebral saturations over the course of the NICU stay. And this is most likely reflective of anemia, as all these babies experience physiologic and, to some extent, iatrogenic anemia. Their cerebral saturations get lower and lower and lower. But IVH influences that even further. As you can see from the yellow line here, babies with grade 1 or 2 IVH have lower saturations the entire hospital stay compared to those without IVH. And those with grade 3 and 4 IVH, the one with the red line, have even lower saturations than those with a low-grade IVH. And this lasts for months, about 60 days before these confidence intervals start to overlap with one another. Even more concerning is this idea of silent cerebral hypoxia. We all are very used to the apnea bradycardia desaturation events that occur in the NICU. It's essentially 100% of babies that are born before 32 weeks. We know this, so this is a nice figure from Karen Fairchild's paper about the frequency of occurrence of these events based on your gestational age of birth as well as your corrected gestational age. And it's not surprising that when you have a systemic desaturation, you would have a cerebral desaturation that goes with it. But what about periods where you have a normal systemic saturation, but cerebral desaturation, silent cerebral hypoxia, in other words? So we investigated this for more than 200 babies, starting from birth all the way out through 2 months of life, and found a couple of things. First, cerebral hypoxia events are very common. There's about 32 events per day shortly after birth, and that increases up to about 50 events per day by the time babies are 3 weeks old. Most of these events that occurred were silent. About half of these events were only detectable with the NIRS monitor, and the proportion that were silent increased for those with severe IVH. 2/3 of the events that occurred for IVH patients were silent. We looked at this in a different way. We looked at it by respiratory support, with the idea that some patients that have severe respiratory disease might have more cerebral hypoxia. That was our hypothesis going into this. However, what we wound up showing was almost the reverse of that. The babies that are on a lot of respiratory support, CPAP, or invasive ventilation spend a very tiny percentage of the time with low cerebral saturations, 1% of the time versus 4% of the time. In general, they have very little cerebral hypoxia. It's the babies that are on low flow nasal cannula, so this is a liter flow less than 2 liters per minute, or those that are on room air that have 8 and 29% cerebral hypoxia burden that really demonstrate that we are perhaps under-supporting these infants. There was no difference between pulse oximetry in these patients, so it is something that is silent that can really only be detected by NIRS. Now, we can also use NIRS in other contexts. We can place it on the kidney, as I mentioned earlier, and it can help us to identify silent kidney injury. We know in acute kidney injury that the laboratory markers we have, things like creatinine or urine output, lag behind the injury itself. It takes time for those to express themselves fully. This is a really nice paper on the top here by Matt Harrer, who's at the University of Wisconsin here in the United States, and he looked at HIE infants that have AKI, which are in red, versus no AKI in blue, and found that almost immediately you can see a difference in their renal saturations. You don't need to wait 48 hours for that creatinine to reflect that. Paige Condit, who is one of his fellows, showed this plot on the bottom here that shows a very nice linear relationship between this change in renal saturations and the change in serum creatinine. So the higher, the greater drop in renal NIRS, the greater increase in the serum creatinine at the end of the day. Other folks have looked at this to help try to manage patent ductus arteriosus. There are several different studies that have looked at this, trying to identify a threshold saturation that can be used for detecting hemodynamically significant PDAs. There are a few papers that are out there. This is a very nice case study right here where this patient was diagnosed with a PDA at the arrow here that says PDA. The orange is their pulse oximetry, and you can see that was essentially normal the entire time. There was really no value there. And their blood pressure of this patient was essentially normal too, but their cerebral saturations dropped precipitously. Right around the time of PDA diagnosis, it was right around 40%. That's quite low. This patient received ultimately 6 doses of indomethacin, and you can see, especially by that 5th dose of indomethacin, we've started to see recovery of those cerebral saturations, and the ductus was finally closed by the 6th dose of indomethacin when we have recovery of cerebral saturations. So now to go through just a couple of case examples. I always like to start with this one because it shows where NIRS is not helpful. This is one of our study patients, and you can see right where this red arrow is, they have this big event, this big heart rate. Their heart rate drops down to about 70. Their pulse ox drops down to about 40. And so it's not surprising that their NIRS, shown in green here, also drops. We don't need a NIRS monitor to help us understand the clinical significance of this event. Where NIRS really shines is in moments of silent change, where we can see a difference on the NIRS monitor before we see anything else systemically. The one on the left here is an example of a patient that had a ventilator adjustment, an increase in their tidal volume, and you can see there's this precipitous drop, a 20-point drop in their cerebral NIRS, shown by the green line here. Their blood pressure doesn't change. Their oxygen saturation doesn't change. Their end tidal 2, however, is dropping because of overventilation in this patient. Now, we don't typically monitor end tidal CO2 in the NICU, so we wouldn't necessarily have this information at hand. But if we were doing routine NIRS monitoring, you would see this sudden change in cerebral saturations, which would lead you to question what is going on in this patient. Another ventilator-related question is found over here on the right. This is a patient on high-frequency ventilation, and you can see the pulse ox in orange is unremarkable, perhaps even a little bit on the high side. It's sort of off of the chart here at the 100% mark. And this patient's blood pressure is also unremarkable for a preterm infant. But when we look at the cerebral NIRS, they're very low. It's less than 60% here. And someone recognized that something was going on, and they realized that the mean airway pressure was set too high, and it was restricting cardiac output and decreasing cerebral perfusion. So when they decreased the mean airway pressure, you can see the cerebral NIRS climb steadily right up to 70%, exactly where we expect it to be. A really nice example of how we can use this as a marker of an otherwise silent problem. These are a couple of examples of hypotension. Many folks, and I would imagine that it's very similar for you, often use the gestational age in weeks as a threshold for blood pressure support when you're thinking about a hypotensive patient. This is an example from Gabriel Varian in Brazil, where he has a patient that has some EEG monitoring on the bottom here, but also has cerebral and renal NIRS in blue and green. And this is a patient that's in septic shock. There you can see that there is a drop off in the saturations that occurs quite precipitously. But the mean blood pressure is not less than gestational age until this moment right here, where the second red arrow, or this red arrow is. But we can see this precipitous drop in the NIRS going back at least 15 or 20 minutes earlier than that. And it's not until the black arrow where inotropes are started and a fluid bolus is started. And it's easy to see in a case example like this where you could get 15 to 30 minute head start on management of septic shock by seeing this precipitous drop in the NIRS that's not reaching that blood pressure threshold until much later. This example on the right here is a very similar thing. This is a baby who's 24 weeks who's becoming progressively hypotensive. Their pulse ox in orange is completely unremarkable. And you can see their blood pressure at the beginning of this recording starts off fairly normal and then decreases and decreases and decreases. But it's not until the red arrow that the blood pressure would be below that threshold of gestational age in weeks. The NIRS threshold is way back here. It's an hour earlier that threshold would have been crossed. So again, showing how this monitor can help us provide a really good head start on our management. These are a few cases of necrotizing enterocolitis. On the left here, this is a patient with congenital heart disease, pulmonary valve artery atresia that developed NEC in the cardiac ICU. The NIRS monitor was placed late. It wasn't placed before the NEC started, but it was placed sort of mid-course. And you can see initially it's quite low. This is from an Invos monitor, and the lowest number that you can record on that monitor is 15. So you can see why it's riding this line of 15 right here. But you can see throughout this, the cerebral, which is shown in black, is preserved. For the cardiac condition this patient has, that's an expected cerebral saturation, and that is preserved. It is purely a mesenteric problem that this patient is experiencing. But there's also recovery. So 24, 48 hours into this monitoring session, you see recovery of those abdominal saturations, and they go back up into the normal range, which gave the providers taking care of this patient the confidence that they had successfully treated the NEC and could restart feeds. Over on the right here is something from one of our research patients who was born at 26 weeks and the donor twin of twin-twin transfusion, and we do weekly monitoring. So this is the mean value during our weekly monitoring session for this patient. And just like the congenital heart disease example on the left, you can see the cerebral saturations remain completely normal throughout the entire recording. The first red arrow, that's where we identified pneumatosis. And this patient got medical management for their NEC. But as you can see, we come back each week and do more monitoring sessions. The abdominal saturations just get lower and lower and lower before they finally hit this point where it's basically, again, riding that bottom line of as low detection as the monitor can provide. So in conjunction with this information, as well as other clinical signs at the time, this patient went for a laparotomy, was found to have extensive necrotic bowel and underwent a bowel resection, and almost immediately, within 2 weeks of that surgery, we can see a rapid rise in abdominal perfusion going back up into that normal range after that necrotic bowel has been removed. This is a great case from Stanford in the US for ECMO complications. So this is the baby on VA ECMO for meconium aspiration syndrome. There's a lot of different channels that are being shown on the screen here. The important thing is that they're normal. The heart rate is normal during this session. The blood pressures are normal. The central venous pressures are normal. What is not normal are the cerebral and renal NIRS that you can see are dropping and dropping and dropping. That's the blue and green in the bottom panel here. That was the first indication to the people taking care of this patient that something was wrong. Now, it didn't indicate what that was, but just that something was going wrong in this case and they needed to address it. So after thoroughly examining the patient, they found on ultrasound that there was a very large pericardial effusion, so a developing pericardial tamponade for this patient, but not so severe that they were tachycardic or that they'd become hypotensive. This was advanced early warning of an impending problem that they were able to drain before the patient decompensated. This is an incredibly invaluable tool in this particular case right here. So what are potential indications for this technology? I think there's really two groups of patients we're taking care of that could potentially benefit. The first is preterm infants. Putting this probe on early helps us to identify cerebral hypoxia and avoid cerebral hypoxia to prevent IVH. Also, using it chronically over the course of the NICU stay helps us to identify these moments of silent cerebral hypoxia, where perhaps we are providing less support than the baby needs with their respiratory support. And it's also invaluable for helping us understand the response to treatments. When a patient becomes hypotensive, when they get transfusions, when we make adjustments to their ventilator, have those changes had the response we wanted? In term infants, I think there's two key applications. One is acute kidney injury, which we talked about earlier, and then as a safety monitoring device during ECMO. That really helps us to identify early those potential complications that go along with that treatment. This all fits into a hemodynamic management strategy. And that's a goal that we've been developing here and many other centers as well, taking advantage of the fact that this is tissue-specific oxygenation and that it is both an indication of a problem and can show us the response to intervention. There are, as I mentioned earlier, some reference ranges that have been published that may be helpful to identify targets. For sure, we should avoid saturations that are less than 45%. There is excellent animal and human data to suggest that that is a critical threshold for hypoxia, tissue hypoxia. One strategy that I really like is this idea of a baseline bottom line approach. This has been used a lot in the operating room, but I think there is a potential use case in the ICU as well, where you start by establishing a baseline. So that is just figuring out what is this patient's normal saturation when they are stable and awake. And then we can use that as a reference point to identify problems later on. So many of the monitors, and this is an example that's shown on the right here, can calculate this for us automatically. If we feel like we are in a baseline state, you can push one button where it makes those baseline measurements, and then it calculates that deviation, that delta from baseline in real time as it occurs. And when there's a deviation of more than 20% from that baseline, that is essentially our bottom line. It should not deviate more than 20%, and that is a point where we potentially provide intervention. So just a few takeaways from the talk today. Hypoxia is a very common problem. Some of it we can recognize with our conventional monitors. A lot of it can only be picked up with a specialty monitor like a NIRS device. NIRS is a composite measure. It provides a measure of both oxygen delivery and consumption, and is really unique in that setting. We can gain a lot of useful information from that combination. It is so helpful for this silent hypoxia, and that is true whether it's cerebral or renal, and that's in the setting where these other monitors that we use routinely show no problems at all. And by using this information, we can provide early goal-directed treatment to patients, and then also measure their response to those interventions with the goal of trying to improve outcomes. So this is just a few articles, suggested reading, and references for the presentation today. And then if you have any questions at all, please feel free to email me anytime. This is my email address. So again, thank you for the opportunity to talk today. I hope you have a wonderful rest of your day.
Thank you, Professor Zachary. I think it is very, well, it's very comprehensive. It's very great lecture. Thank you for telling us about mechanism and silent of NIRS. And I'm sure that after they know about the silent of NIRS, And your example, some very interesting case, they can integrate the NIRS tool in their clinical practice. That when we come with a poll, what percentage of neonates with a CHG, congenital heart disease, would have the preoperative brain injury seen on MRI? Do you guess what? From 5 to 10, 10 to 20, 20 to 40, or 40 to 60%? The thumb is up, and now, well, we see in the full range of the answer, and the correct answer is 20 to 40%. Is the right answer account for that's 1/3. And the point number 4, management option for reduction more than 20% of the cerebral NIRS value during the congenital heart disease include all, except what? Except increase the FiO2, reduce the PaCO2, optimize the cardiac output, or check for the cannulation position during CPB. Kindly remind that you will choose the wrong answer. You need to choose what except. Well, now we have 60%, 66% is the right.
Again, thank you, Dr. Dr. Zachary, for his very comprehensive speech. Now, it's my great pleasure to announce our second speaker, Dr. Kamlesh Taylor from India. He is the lead consultant of pediatric cardiac anesthesia and intensive care in Kokliban Ambani Hospital in Mumbai, India. And he works as a fellowship also in Faculty for Pediatric Cardiac Intensive Care Unit and Cardiac Anesthesia. And he's also an academic council and EC member, IACTA. His interests are neonatal complex congenital heart disease, pediatric ECMO, and pediatric heart transplant. Now, Dr. Taylor, we are listening to you.
Good afternoon, everyone. Is my screen visible and I'm audible? I'm able to, my voice is clear and my screen is visible?
Yes, Dr. Taylor.
Yeah, good afternoon, everyone. Greeting from Mumbai, India. My name is Dr. Kamlesh Taylor. I'm working in Kokliban Dhirubhai Ambani Hospital in a Children's Heart Center as a lead consultant in pediatric cardiac anesthesia and ICU. Today, I'll be talking about NIRS in pediatric cardiac surgery. I'd like to thank ASPA and team for providing me the opportunity to speak on this topic. My topic outline will be, I'm going to cover a few slides on how much the brain injury can happen during pediatric cardiac surgery or neonatal cardiac surgery. A few slides on NIRS basic. We'll be discussing about cerebral desaturation intraoperatively and its management, and a few slides of my own experience about the NIRS and some take-home message. As the previous speaker also mentioned, a brain is a highly metabolic organ and it consumes almost 20% of total oxygen. So any injury or any kind of injured or any compromised circulation happen during the pediatric cardiac surgery or neonatal cardiac surgery, it's the most vulnerable organ to get damage. This neonatal brain, which is pre-myelinated white matter, is particularly susceptible and at risk for any acute insult. Periventricular leukomalacia, which is also known as PVL, is a common pathway of a response to injury of the perinatal brain. It will be this injury, and with periventricular leukomalacia, it will be irrespective of the duration of DSCA at the time of which time the surgery has been performed or modality of the surgical procedures. But hypoxemia, hypotension, particularly diastolic hypotension, are the most important risk factor to develop such kind of brain injury, especially in neonatal or infantile age group. If we can, one of the articles has been published about preoperative MRI on the neonate, those who are having a congenital heart disease or a complex congenital heart disease, and they have seen almost 20 to 40% of this brain is already been having some kind of injuries. And if these patients are being exposed for pediatric or infantile heart pediatric cardiac surgery, the new parenchymal brain injury can be seen on MRI in almost 36 to 73% of these patients. Dr. Jill Barnowski has been published this in Cardiology of Young in 2006 that neurodevelopment problems, which is a long-term problem after infant congenital heart surgery, the incidence is as high as 20 to 70%. So even the other two studies have been kind of published in related to long-term problem of problem with pediatric cardiac surgery, the Creighton and Megenemer. These two studies have been mentioned that 26% of these patients or children who are exposed to pediatric cardiac surgery has low IQ. 50% of these children having gross motor deficit, and almost 40% of these patients will having a fine motor deficit at the age of 5 years. So problems are huge. This injury can be occurred because of ischemia, reperfusion, and then later on either it will be cell repair or cell death. It can be involved either a brain, spinal cord, or peripheral nerve. The extent of injury can be a global or focal, and etiology can be hypotension, hemorrhage, ischemia, infarct, or embolism. There are other kind of many factors which affect the brain injury during pediatric cardiac surgery. Some of the drugs can cause this. Low cardiac output perioperative, hemoglobin level extreme level of extreme low or high hemoglobin, same as blood sugar level also. Systemic inflammatory response, intracranial bleed, deep hypothermic circulatory arrest, or collaterals, or some perfusion problems. We are discussing here about the use of NIRS in pediatric cardiac populations. NIRS is a near infrared spectroscopy. If we see that oxygen monitoring at different level, suppose if you are monitoring the oxygen at the arterial level, which is SaO2, it is just show us oxygen availability. If you're putting a pulse oximeter and monitor the oxygen level, the pulse oximeter pulse oximeter shows a pulse flow depend on the pulsatile flow. It measures only oxyhemoglobin, and it will tell us only the supply. It will not tell the delivery of tissue oxygen is adequate or not. If you are monitoring mixed venous saturation, it will give a global picture of oxygen uses, but it may not reflect which organ has been properly supplied or not. Needs of cerebral oximetry, or sometimes we are placing it somewhere else like pancreas or kidney. It shows us a difference between oxyhemoglobin and deoxyhemoglobin, or in other words, if you can say, venous oxygen reserve capacity of that tissue where we have actually placed the sensor. It is the most important thing, it is non-invasive. It shows the regional oxygen saturation, and it can be used at the multiple places like cerebral, renal, splanchnic, and it shows as a spurious speaker benson venous, predominantly venous saturation, or we can say a reserve oxygen on that tissue. This has also been discussed in a previous speaker. The NIRS work on a banana-like arc, emitted light follow the predictable path, resemble banana-like. The deeper signal crosses to the tissue to deep as much as 2.5 centimeter, and the superficial signal will kind of remove all the artifacts. How to use this NIRS in pediatric cardiac patients? It has to be used bifrontal and should be used at least hairless area of a forehead. The baseline saturation of NIRS saturation should be done after giving minimal sedation or without sedation, and then you need to monitor throughout the surgery. It can be monitored and managed by two strategies: either the deviation from the baseline if more than 20 to 25%, which suggests there is a significant fall of NIRS and you need to take action about that, or overall NIRS value goes below 50%. The paper from Boston Children's Hospital on NIRS and pediatric congenital heart disease, they have published in 2020 and come up with some algorithm how to manage this desaturation related to the cerebral oximetry. If the saturation of cerebral oximetry comes down to less than 60%, if there is a downtrending, left and right NIRS value difference is more than 10%, and the NIRS saturation is not increasing with the cooling, then I think base thing is you need to check about airway and ventilations and oxygenation. Other thing we need to check out before taking action is whether the placement of a probe is okay or not, skin contact is fine or not, or the signal quality is adequate or not. If these are then been ruled out, then it can be divided into cerebral delivery of oxygen and cerebral requirement of oxygen. If a cerebral delivery of oxygen, if you are discussing, it is further divided into if a patient is on bypass or not on bypass, or patient is either ICU or cath lab. If that is a scenario, then increase the effort if it is required. Exclude the hypocapnia, or if you are hyperventilating, reduce the ventilation to bring up the PaCO to more than 35 or 40 range. Optimize the arterial blood pressure or cardiac output, either giving fluid boluses, starting inotrope vasopressors or vasodilators, whichever the therapy is needed for appropriate for that patient. If a hemoglobin level is lower in a particular patient, especially in a cyanotic less than 30 hematocrit or a cyanotic less than 40, consider transfusion PRBC. If a patient is on cardiopulmonary bypass, first to exclude the malposition of aortic or venous cannula, then discuss with the surgeon. If that has been ruled out, then discuss about the CPP adequacy or not, adequate CPP perfusion is going or not. See the PaO2, SaO2, how much FR2 they are keeping, how much flow they are keeping, and how much mean airway pressure they are keeping. If these are the things is fine, then ultrafiltrate or increase the hemoglobin level on pump and check about the PaCO2 level. In a special consideration, during the retrograde cerebral perfusion or antegrade cerebral perfusion, increase the amount of blood you are delivering to those kind of a segment. And if you are on the hypothermic circulatory arrest, if saturation is lower than 45, try to reperfuse and restart again if it required. If a patient's then consider about how the demand is increased or not. If a demand is increased, then either increase the depth of anesthesia or give us sedation, prevent hypothermia, consider mild hypothermia, rule out and treat seizure as well as intracranial pathologies. Increase, if a patient is on pump, then increase the depth of anesthesia, cool the further, and place the ice around the head and prevent excessive rewarming from the CPP end. This has been simplified way of, it's been published previously in 2013. This is a simplified way of saying is if the cerebral desaturation is there, then check the aortic and venous cannulation, check the mean airway pressure is fine or not, check the saturation, and if require increase FO2, check the PaCO2 optimize it, check the hemoglobin optimize it, check the cardiac output and mixed venous oxygen saturation and optimize it. If these are the things are fine, then reduce the requirement of oxygen by hypothermia or anti-epileptic drugs. And if there is a problem with intracranial bleed, treat it. So this is a way we can manage the patient of NIRS desaturation during the intraoperative pediatric cardiac surgery. This is a publication from JCTVS published, and they have taken in a meta-analysis about what we should know and how to use NIRS in pediatric cardiac patients. They have considered 54 manuscripts and 13 review, and they have concluded that many and even many centers, even most of the country has been adopted now NIRS as a standard of tools, and it will be useful during the pediatric cardiac surgery. Still, some of the data of clinical correlation and outcome is not been established, but it will be gradually soon. The further studies come and give more highlights about this. In a World Journal of Pediatric and Congenital Heart Surgery, also they have emphasized, and if this is from the Texas Children's Hospital, and they have mentioned about if somebody is using a specific cannulation technique like antegrade cerebral perfusion or retrograde cerebral perfusion, and to check the adequacy of the perfusion to the brain, one has to be kind of monitor NIRS and or transcranial doctor. This paper has been published from Royal Children's Hospital, Australia, the use of NIRS in pediatric cardiac ICU. And what they have found in few of the studies about if you are using venous saturation in septic shock, which has been already discussed by a previous speaker, that if you act on the lower saturation, the survival improves. Use of cerebral oximetry of venous saturation post Norwood, which will increase the survival rate. there is a use of renal and cerebral NIRS combined, and that will provide us better, strong indicators about patients is doing well and the lactate levels is fine or not. Cerebral and renal somatic NIRS in post-operative, this will combine so as a global oxygen economy after complex cardiac surgery. If a cerebral and mesenteric NIRS, this has been case discussed by previous speaker, that if you are using a mesenteric NIRS along with the cerebral, you can definitely predict the necrotizing enterocolitis post-operatively. Renal NIRS post-operatively in post-Norwood patients, if it is significantly low, that will suggest early renal failures in post-op period. And the last is if neonatal single ventricle population, if you are using venous oxygen saturation by using NIRS, if it is significantly low, less than 55, this child will associated with impaired neural development problems later on. This cerebral NIRS has been used even during the resuscitation also, and this is a paper published from UK. They concluded that if you are using NIRS during the resuscitation, the higher and initial average of regional cerebral oxygen values both are associated with greater chances of achieving ROSC in patients suffering from cardiac arrest. And one step ahead, the Boston Children has recently published a paper which they are using NIRS to predict the cardiac output, and they have concluded here is at 1 hour before the event, for every 10% increase in the SpO2 and R regional cerebral oxygen difference, the odds of cardiac arrest increase by 40%. This is a very bold and significant statement to use NIRS in pediatric cardiac ICU. Few of the my indications, when we started NIRS, we were very selective in the using NIRS, but now we are using in almost all cases. Initially, we started with neonatal complex congenital heart disease, including hypoplastic, interrupted aortic arch, coarctation, or hypoplastic transverse arch, TAPC, TGA neonate, and shunt surgery. This is one of the case where we have come across. We were repairing the arch, and we have done innominate cannula. After putting innomination cannula and starting a circulation, we found that there is a significant drop in NIRS. After discussing with the surgeon, they have adjusted the cannula position, and then gradually the NIRS value goes up. Pediatric age group in a pediatric cardiac patients, where I am using is severely cyanotic child with come for corrective surgeries. Heterology followed with multiple AP collaterals where there are chances of coronary steal during the pump run, and we need to monitor the NIRS value during the pump run. Bidirectional gland surgery, when we are temporarily clamping the SVC and gradually the venous pressure increases, and the same way the brain congestion increases. To avoid any brain injury, we need to monitor the NIRS value here also, and for the redo surgery, obviously to overall guide the procedures. This is one of the cases where we are performing reduced sternotomy, and there was a accidentally hole in the atrium. We found there are a lot of blood coming from the below the sternum, and there was a significant hypotension along with low NIRS saturation. We were able to tackle this, but it took long time, and then post-operatively this patient was having some CNS problem. We are using modified ultrafiltration in all our complex congenital cases, especially in neonate. And we were discussing here during the MUF, we are taking blood from the aorta, putting into the filter, removing a lot of fluid, and increase hemoglobin on concentrating it and giving back to the venous cannula. By taking some blood from the aortic cannulation, we were debating about that whether we are taking the blood which is causing cerebral steal or not. And to demonstrate whether we are affecting the brain perfusion or not, we have performed 32 cases study. And what we found is our NIRS value, initially after starting MUF, there was a small dip, but it was not significant dip. And then gradually the NIRS value settled during the MUF. And then at the end of modified ultrafiltration, we found in almost all cases, there was a significant rise in the NIRS value. The rise in NIRS value at the end of a MUF, reason behind this is because we are hemoconcentrating this patient at the end of a MUF. At the end of a MUF, the perfusion start giving some volume. So here we are increasing the preload, that is also increasing the NIRS value. And at the end of a MUF, we are removing a lot of inflammatory markers and reducing the myocardial edema, which will overall improve the NIRS value. So these are the 3 or 4 reasons where our finding of NIRS increase at the end of a MUF established. we are using deep hypothermic circulatory arrest in many of the cases. And before the NIRS introduced in India, we were doing deep hypothermic circulatory arrest every 15 minutes. It is called as intermittent hypothermic circulatory arrest, where 15 minutes we'll do DHCA and then reperfuse for 2-3 minutes. Again, we go back on DHCA if it is required. But after introducing NIRS, what we have added in our protocol is, if a NIRS value on the DHCA fall down to 40%, or even though there is no 15 minutes, I think we again restart the circulation, achieve what the normal NRS value which was there before starting DHCA, again go back on DHCA if it is required. This is which has been showed in this slide, and then this will definitely having a better outcome in our own unit. This is another slide where we are performing DHCA, intermittent DHCA, along with the NIRS monitoring. We have done cases of 30 where we put a renal NIRS and want to find out the impact of renal NIRS or monitoring renal NIRS and incidence of postoperative AKI. We are unable to found any correlation, because we found only one patient had AKI and there was no much correlation. But incidentally, we found surprising two observations where hypothermia during the CPB, the renal NRS value, which is gradually increasing, like temperature 33, temperature 30, the renal NRS value keep on increasing. The second observation, what we found is the impact of hemodilution on renal NRSs. And reducing the hematocrit, what we found is there was an increase in the NRS value during the surgery. We have published this case where we have used an ECMO in a single ventricle Norwood because the child was arrested in the ICU. We put on ECMO, and then we have used NIRS here to monitor, because we are not clipped the shunt, and then we were thinking about whether we are stealing the blood from the brain, and the best way to monitor is NIRS and see that how much the value is there. And then what we found that the NIRS value was okay. We were sure that we were not causing cerebral hypoperfusion. And this case later on we weaned off from the ECMO and could able to discharge without CNS problem. This was one of the case where we found that there was a pump failure, CPB pump failure, and then significant drop in NIRS value along with the desaturation hypotension. We manage it later on with the proper perfusion results. This is an interesting slide that use of NIRS for as an adjunct of cardiac output monitor. What we have found is that in a NIRS value, even though the mean systolic or diastolic blood pressure fluctuates minimal, we found there are significant changes in NIRS, and if we appropriately manage during that time before even significant hypotension, I think we are able to tackle those problems. We have seen that the significant drop in NIRS value in association with arrhythmias also. And there is this paper is also suggesting that NIRS value is very much kind of correlating with the mixed venous oxygen saturation. Lower the saturation, lower the NIRS, and gradually the mixed venous saturation goes up to 50 and 60%. The NIRS value increases. To conclude my presentation, I can say that brain injury is common and serious after pediatric and neonatal cardiac surgery, and the mechanism also is complex. There are few evidence and established practice to prevent perioperative brain injury. The diagnosis and preventive measure is the key, and then here we have one tool where we can able to monitor to some extent. We can predict also, and if we able to treat that as early as possible, we can significantly reduce the perioperative brain injury during the pediatric cardiac surgery. Thank you so much.
Thank you, Dr. Klas. Thank you for your lecture with many evidence and application of the NIRS in the during and in the ICU for the cardiac surgery, with the emphasis on the brain protection, which is a very vulnerable and critical organ during the open heart surgery. Now we come with a point number 5. What does a near zero difference between the somatic regional saturation and cerebral regional saturation indicate in the neonate post-cardiac surgery? It says that it improves the systematic oxygen distribution and reduce risks of complication. or increase the cerebral perfusion with no impact on organ function, or high risk of biochemical shock, organ dysfunction, and death, or no significant correlation with the clinical outcomes. Wow, you have 44% as the right, which is the high risk of biochemical shock, organ dysfunction, and death. But still many other choices. And the last point, what is the key principle of the baseline and bottom line approach for the NIRS in pediatric anesthesia? It's waiting until the CRS saturation declines below 50 before initiate treatment, or using a fixed CR saturation threshold for all the patients, or you need to maintain a cerebral oxygenation above the awake baseline to prevent this, or ignore the device-specific variability in the CR saturation measurement. The time is up, and we have 62% as the right. You need to maintain a cerebral oxygenation above the baseline, the awake baseline, to prevent it.
Again, thank you, Dr. Kamlish, for your very comprehensive speech. Now, it's my great privilege to introduce you our third speaker, Dr. Unikrishnan. He works as a cardiac anesthetist in the Department of Anesthesia, Sri Chitra Tirunal Institute for Medical Sciences Technology in Trivandrum, India. His interests are cardiac anesthesia, transesophageal echocardiography, and research. Now, Dr. Unikrishnan, we are listening to you, please.
Thank you. Thank you for the nice introduction, and very good evening to all of you. It's a fine Sunday. Now, I've been asked to present a topic on integrating the NIRS to the goal-directed therapy in pediatric cardiac anesthesia. So previous two speakers have already covered most of the aspects of NIRS in pediatric cardiac surgery. So I would like to divide the presentation into some of the basic aspects, why the NIRS is becoming popular. Not only popular, that's becoming a standard of care in pediatric cardiac surgery and anesthesia. And our unit experience, one of our projects in NIRS in pediatric cardiac surgery, I would like to share our findings too. So I have no conflict of interest. Could you please change the next? Okay. So the low cardiac output syndrome is a very frequent complication following congenital heart surgery. To look at it affects almost 25% of patients who undergoes biventricular repair, and even higher incidence and severity has been observed in univentricular heart disease, who is undergoing simple ventricle palliation. So what we conventionally use our standard monitoring to look for the oxygen delivery, like ECG, blood pressure monitoring, filling pressures, arterial saturation, and intermittent physical exam and blood gas analysis. They have limitations because of the poor reliability and has got a limited diagnostic accuracy in detecting the low cardiac output syndrome in most of the patients. And early detection and aggressive management is extremely important to improve outcome in these children. Next slide, please. Next slide, please. So we have seen that the previous speakers have already mentioned about how well the NIRS value, cerebral NIRS value is correlating with the systemic venous oxygen saturation or mixed venous oxygen saturation. There are significant data is available. For example, Resusi et al. Into an observational study, they have found that cerebral regional saturation has a strong correlation with the central venous saturation or SVC saturation, especially in cyanotic patients. Kaufman et al. Has shown in an observational study in children undergoing cardiac surgery, the regional saturation measured from either flank or abdomen, the somatic regional saturation, they have correlated with the systemic venous saturation. So NIRS, actually, we have previous speakers have all mentioned about most of these studies. So we can say that the NIRS serves as a reliable trend monitor with a cerebral regional saturation changes that can reflect the systemic venous oxygen saturation. Next slide, please. So what we are now interested in is multi-site NIRS monitoring, and the NIRS sensor can be placed not only at the frontal area, but it can used to measure the somatic saturation, especially renal saturation, mesenteric muscle saturation, so they can get a regional perfusion data. So two-site NIRS monitoring has found to be superior than a single-site monitoring for estimating the systemic venous saturation. There is again supporting evidence of using the multi-site NIRS is available. The Chakravarti et al. Again, Dr. previous speaker has already mentioned about these studies. They are shown in the table. So in this prospective study, he has found that, the Chakravarti et al. Found that average cerebral and renal regional saturation correlated well with the lactic acidosis in children in the post-cardiac surgical period. So the key finding is when you average these saturations, cerebral with the renal saturation, if the value is found to be less than 65%, the predictor lactate rise is more than 3 millimoles per liter, so which has got a very high sensitivity of 95% and specificity. So the significance of these observations is that NIRS, the multi-site or two-site NIRS monitoring can be used as a strong predictor for global oxygen economy. It helps to identify patients at the risk of metabolic distress at a much early stage. Next slide, please. So, what is the importance of this two-site NIRS monitoring, especially when uses for a flagging circulation monitoring? So, we have found that actually there is a significant degree of systemic flow redistribution happens in these children during the pediatric cardiac surgery. It could be due to sudden acute loss of blood loss, maybe because of some hemorrhage. It can actually shift causes sudden mesenteric vasoconstriction. This is a shock-like situation. This is protective reflex to redistribute the blood volume into the vital organs, which was got a very definitive autoregulation. So blood is usually diverted from the renal mesenteric or plantar regions to the vital organs brain, which has got a autoregulation. So the two-site NIRS monitoring identify the changes in blood flow distribution caused by because of the sympathetic activation which happens in the shock, or it happens during the cardiopulmonary bypass, the inflammatory cascade due to the systemic inflammatory cascade, and also very frequently we use vasoactive drug treatment for optimizing the cardiac function, which may have got effect on the mesenteric circulation. Next slide, please. So if you look at the clinical study done on mesenteric and cerebral NIRS in neonatal patients undergoing cardiac surgery, what they found that actually this is again done by Hoffman. He has done a lot of study in NIRS in pediatric cardiac surgery. What they have found that there is a reduced gradient between the mesenteric and cerebral regional saturation. So normally, as the previous speakers all mentioned, the brain is the maximum metabolic organ. It extracts the oxygen much higher than the other organs. So typically, if you look at the mesenteric saturation, plantar saturation, usually it is 10 to 20% higher in the normal cardiac output state. But this is because there are low Fc extraction in these tissues. So if you look at the mesenteric saturation and in relation with the cerebral saturation, and its absolute difference between these two saturations, if it approach reduces and it approaches to zero, there is an increased risk of biochemical shock, organ dysfunction, and increased mortality. So this has been observed by Hoffman et al. And published in Anesthesiology in 2004. So multiple prospective studies also confirm that the NIRS can assess the global oxygen economy and identify the perfusion abnormalities in neonates and infants after complex congenital heart surgery. Next slide, please. So NIRS can provide valuable insight into the mesenteric perfusion. So again, another study by Fortune et al. When they applied the NIRS sensor onto the anterior abdominal wall near the intraumbilical region that detects the mesenteric splanchnic perfusion. So any early signs of organ dysfunction in terms of necrotizing enterocolitis, again, Dr. Doctor has very nicely explained in the ICU setup. The risk prediction of the neck can be done when you use a two-site NIRS monitoring. If the ratio of a somatic to the cerebral region of saturation goes down below 75%, there is an increased risk of necrotizing enterocolitis in babies in a range of 8 times. So this can be used as a marker to look for a compromised splanchnic circulation in this patient, and this has got a high sensitivity of again 90%, highly predictive for neck development when you use two-site monitoring involving mesenteric saturation. Next. So again, with the renal monitoring, we can place the sensor in the flank region, which will detect the venous saturation from the renal vein IVC that usually correlates well with the renal perfusion and the renal oxygen utilization. So, and again, Hoffman, they have observed in children units undergoing normal procedures, a low renal regional saturation in the first 24 hours in the postoperative period has a strong correlation with the renal acute kidney injury or renal failure development by postoperative day 3. So it has got a clinical implication. Two-site monitoring, the ratio somatic to cerebral regional saturation can serve as an early warning sign for necrotizing enterocolitis, and low renal saturation monitoring may predict postoperative kidney dysfunction. Next slide, please. And NIRS monitoring and it's a long-term neurodevelopmental outcomes. Again, this has been explained by the previous speakers. Okay. And again, Hoffman, they have published a very good article in neonates with a single ventricle palliation, average cerebral regional saturation less than 55% for the in 48 hours after the surgery has a strong correlation with the impaired neurodevelopmental outcome, which was measured at the school age using a Beery test, where impaired visuomotor integrations were observed. So even long-term neurocognitive negative neurocognitive outcome is demonstrated when there is a perioperative cerebral desaturation. So NIRS can be used as an early detector of organ injury. Prospective observational studies confirm NIRS can detect perfusion abnormalities not only in the brain but in gut, kidneys, and so NIRS has become a standard of care in pediatric cardiac surgery. Next slide, please. Note, can the NIRS can be used as a primary target parameter for goal-directed hemodynamic management? That's the question. So the Scott and Hoffman, they have described they have published in Paediatric Anesthesia that the NIRS opens to a window of regional circulation monitoring that can drive organ-specific goal-directed treatment. Why NIRS is so superior to the traditional parameters? So whatever the traditional parameters, the conventional monitoring we are using, they are actually the downstream monitors. Actually, it will provide the idea about how much oxygen is delivered to the tissue. But what is actually happening at the tissue level, how this oxygen utilization happens, most of our conventional monitors do not give a reliable answer. So here comes the NIRS, the value. Is only other conventional parameter which may give a downstream view is the lactate levels, but it is invasive and continuous lactate level is not very feasible in every setup. So NIRS, being it a non-invasive, a real-time measure of the oxygen supply demand balance, that becomes a big useful parameter and can be used as a primary target parameter in hemodynamic management. And the conventional parameters like blood pressure, heart rate, arterial CO2, all can serve as a contributors to maintaining the cerebral oxygenation. So what is important is the simultaneous interpretation of the NIRS value with the contributing parameters provides the most accurate assessment of the perfusion. Next slide, please. So how you do it actually? First, we need to establish a baseline cerebral regional saturation measurement. Why? Because there are different types of devices are available and their algorithms are proprietary and they are different. Okay, so one machine giving a NIRS value which may not be comparable with another device in the same setting. So, but that cannot be a limitation if you take the baseline value as your target parameter. So the key factor is we have to establish an individualized target value. That is the best. Most often we rely on the baseline value. So why? Because in baseline, when the child is awake, we assume that the cerebral oxygenation is adequate and the cerebral perfusion is also adequate. The crux is we need to stick on the target parameter is the awake baseline NIRS value. Next slide, please. So this is a baseline bottom line approach, again described by Frank Weber, published in Paediatric Anesthesia in 2019. So here they describe that they use as the individualized cerebral region saturation target. Again, the target is the awake baseline NIRS value. Now we know that our conventional parameters are actually contributing the cerebral saturation here. Okay, so if the idea is to maintain the base NIRS values just above the baseline saturation in the intraoperative period. This is called a proactive approach. So we don't need to wait the desaturation to occur or it goes down significant level more than 20%, then treat it. So whenever it tends to reduce, then try to manipulate the contributing factors in such a way that this can restore back to the above baseline level. So this is the concept of a baseline bottom line approach. Next slide, please. So how we can do this? So we should know how the NIRS values behaves in a typical anesthesia time when you are inducing the child scheduled for a pediatric cardiac surgery. So we need to attach the sensor before anesthesia induction at every stage. So as I mentioned, that actually represent the adequate cerebral oxygenation state. And if possible, the conventional parameters has to be recorded in the awake state itself. There can be challenges in measuring baseline blood pressure in all neonates, and sometimes challenges can happen in a sensor placement to get an awake baseline cerebral regional saturation. But the Weber's article, they could achieve almost 100% success in sensor placement in the awake state in all neonate and infants undergoing surgery. Next. Now, the stabilization requires only less than 1 second. So once the sensor is placed, once you get the baseline value after 1 minute of stabilization, then that should be used as a target parameter. So if those children are distressed during induction, prior to induction, that can affect the baseline value, especially when the child is crying. Then it can increase the intrathoracic pressure. That may alter the jugular venous rhythm. So what happens? The venous compartment in the brain, the percentage can increase since the sensor is actually sampling a unit area which has got almost 70-75% of venous compartment, 25% of arterial, and 5%. It depends upon the algorithm of the device users. But when there is an increase in jugular venous pressure, the venous compartment can increase. So it can sample more venous sample. So the regional saturation can go down baseline when the child is in distress. Next slide, please. But after induction, when you use, once the patient goes a loss of consciousness after anesthetic drugs, the cerebral saturation level must increase at least by 5 to 10% from the baseline awake status. This is because the reduced cerebral metabolism due to the anesthetic effect. If there is a reduction in cerebral saturation occurs during induction, that indicates either the ventilation is not adequate or there is a systemic hypotension developing that may be causing cerebral desaturation. So here again, during induction, NIRS can react faster than any other conventional monitor, and it will be very useful as a real-time warning system in typical group. And during maintenance, what we assess, okay, so we can get, then typically the NIRS value will be slightly lower than the induction, but always higher than the baseline value. This is because during induction we use higher fraction of spared oxygen concentration. But typically this baseline, the maintenance value should be at or above the baseline saturation. Any reduction in saturation, that could be most common cause is the systemic hypotension. Next slide, please. So in the step-by-step approach of NIRS to directed hemodynamic management, in baseline bottom line approach, do not accept any cerebral regional saturation less than awake baseline. If there is reduction in the saturation level, immediate attention for the conventional parameters and manipulate those factors to restore back to the baseline. So BP management strategy, maybe we may have to use noradrenaline infusion or phenylephrine calcium bolus, or fluid bolus may be required. When you are handling with a preterm neonate, large fluid bolus may not be can be detrimental. It can cause respiratory compromise. So a judicious use of a combination of fluid with vasoactive agents is essential. Now, if you look at what is the level of evidence of baseline bottom line approach, it has got only level 3 recommendation. Okay, so there is a scientific data is lacking. So mainly because there are no robust studies are available using the NIRS. RCTs are not available, but there is consistent findings are there. There is a frequent cerebral desaturation, more than 20% occur during neonatal anesthesia, and whenever there is desaturation more than 20%, they are actually associated with a negative postoperative neurocognitive function. So even a moderate desaturation declines may impact the patient outcome, and it should be avoided. There is urgent need for more scientific data to evaluate the NIRS effectiveness is needed. Now coming to the multimodal neuromonitoring approach, how to reduce the neurological issues. There is only one RCT available. This is a landmark study by Austin and colleagues, which was way back in 1997. They have published actually in 250 pediatric patients. They have used neurophysiological monitoring, NIRS, involving NIRS cerebral saturation, transcranial Doppler, medial cerebral artery flow velocity, and EEG for looking for the amplitude and related delta power in patients undergoing cardiac surgery. So what they found that those patients who had any changes in this one, any reduction more than 20% from baseline in NIRS value, or MCA flow velocity, more than 50% reduction from baseline, or less than 20 centimeter per second flow velocity, or EEG amplitude reduction, or relative delta power into the total power, if it is increasing more than 80%, that is slowing of the ECG. So all these can be are used as a positive changes. Then in one group the intervention is done, other group there is no intervention, only monitoring is done. What they found that interventional group had a significant reduction in postoperative neurological sequelae and reduced hospital stay. But this requires an extensive resources and very expensive. Now, with this background, I would like to share our experience from our institute. We have done a comparison of a cerebral and mesenteric NIRS for early detection of low cardiac output symptoms in pediatric cardiac surgical patients. Next slide, please. So here the primary objective was to look for the overall incidence of cerebral desaturation and assess the efficacy of intervention protocol to treat the cerebral desaturation. And secondly, we tried to observe the correlation between the mesenteric to cerebral gradient, lactate level, CVP, vasoactive scores, mean blood pressure, and heart rate in both groups. Basically, the idea was to identify low cardiac output state in children undergoing pediatric cardiac SIG. Next slide, please. So, a total of 40 patients were included, intervention group 20 and control group 20. Next slide, please. And there was a feasibility was assessed in 45 patients we had to exclude. Next slide, please. Inclusion criteria is pediatric patient under 14 years with a RAC score of 1 to 2 with a normal GCS were enrolled, and GCS less than 15, and premature infants and children with a multi-organ dysfunction were excluded. Next. Study protocol, the institutional ethics committee approval one CPRI registered. Next, please. So, what a standard anesthesia protocol is used as per the attending anesthesiologist. What we have done is before induction of anesthesia, 2 NIRS sensors were attached, one for cerebral, other for the mesenteric saturation monitoring. Those children who are uncooperative and fretful, their sensors were placed just soon after the induction. Next slide. So we measured the baseline cerebral tissue oxygenation is recorded, and data is recorded at important time points like pre-induction, post-induction, median sternotomy, start and end of CPD, moderate hypothermia, aortic unclamping, after sternal closure, pre and post-extubation, and vital signs like heart rate, mean blood pressure, central venous pressure, temperature, urine output, ABGs, and serum lactase were measured. Next. So in the interventional group, what we did, whenever the cerebral saturation level, we have established the baseline saturation, whenever the cerebral saturation dipped to 10% from the baseline, the interventional protocol were initiated. And the idea, and even after the initiation of the intervention protocol, more than 30% drop in desaturation we recorded as a significant cerebral desaturation. In the other control group, we applied the sensors and monitored, but the values were blinded and standard hemodynamic protocol were followed. Next slide. So this is a algorithm which we are used. Again, the algorithm was very nicely explained by Dr. Kamalesh in the previous. I'm not going to the detail of that algorithm. So we are okay. So statistical analysis was done. Next slide, please. And in the results, the demographic, based on the each group, age, weight, and the gender, there is comparable, no difference at all. Next slide, please. So these are the surgeries the patients were enrolled. So both cyanotic and cyanotic congenital heart disease were involved. ASP closure, so you can see the interventional group and control group. ASP closure, DDG, PCPC, all these procedures, SAM excision with AV valve repair, AVCD repair, and both congenital and cyanotic congenital and cyanotic patients are involved. Next slide, please. So what is important here, when we measure the cerebral saturation and mesenteric saturation, baseline saturations were assessed. Here you can see that in the interventional group, both groups actually, there is a negative gradient exists between the mesenteric and cerebral saturation. Okay. Was a surprising finding. Normally, we should expect a higher mesenteric saturation than the cerebral saturation because extraction in these regions are less. So even after the induction also, this negative gradient, MC gradient was found to be negative. Next slide. So we compared the cyanotic and cyanotic. Again, the saturations were comparable, but there was a negative gradient observed between the mesenteric and cerebral saturation. Next. So this was very surprising. So, and the explanation for this negative mesenteric to cerebral gradient is that it is basically due to the redistribution of the blood flow happens in these patients, especially these children are fasting, preoperative NPO status, and most of these children are having left-right shunting with the pulmonary overcirculation. So all these can, and some patients were associated with ductus also. So they are having a preferential pulmonary circulation, healing the system itself. That actually reduce the MC gradient in this patient. So this reduced gradient could be with a normal cerebral saturation could be an early marker of the low cardiac output in this patient. Next. And our primary outcome that we analyzed the overall desaturation episode, the overall incidence of cerebral desaturation, more than 20% drop. We found out 42 episodes. If you look at the control and interventional group, in the interventional group, we were able to reduce 52% of the total desaturation by implying the treatment, and it was statistically significant. So in comparison to the previous study by Subramani, where they could actually reverse the desaturation by 92%. Next slide, please. So the intervention which we use most commonly is mean arterial pressure adjustment manipulation, followed by hemoglobin. That was the commonest management we did. Next slide. So it is, if you look at the cerebral value desaturation, it is interesting to note that there is no much desaturation happen after weaning from CPT in the intervention group compared to the control group. This highlights the efficacy of the NIRS monitor or routine methodology of hemodynamic management. Next. And the secondary outcomes, when we compare with the lactate level and vasoactive inotropy score, there is a significant reduction in the lactate level and vasoactive inotropic requirement in the intervention group compared to the control group. That suggests a better management of hemodynamics in the treatment group with the NIRS. Next slide, please. And in the conventional parameter, what we found that there is a higher CVP, higher filling pressure, and a lower incidence of tachycardia, lower heart rate in the interventional group, suggests a better preload optimization. This implies the efficacy of the NIRS monitor in early detection and optimization of the low cardiac output state. Next. So what is interesting here, if you look at the MC difference, mesenteric to cerebral difference, though the baseline MC difference was slightly negative, so this is we have explained. But when the patient went on bypass, actually the gradient becomes positive. This was expected. Okay, and towards the end of the surgery, after weaning from bypass, again the gradient actually reduced, and it was almost reaching to the zero level. So there is a negative correlation, and there was a negative correlation between cerebral mesenteric saturation and temperature while on CPT. Next. So the explanation which we found out that in most of these patients, after weaning, almost all patients undergone MUF, modified ultrafiltration, and the cuff was going on, and this inflammatory cascade due to the hypothermic CPD and the routine use of diuretics in the peri-extubation period all can reduce the intravascular volume. So if you look at the cerebral saturation alone during the MUF, actually Dr. Kamalesh has shown it dipped initially and increased. But what happened here, in MUF and this cerebral saturation is maintained, but there is a mesenteric saturation is going down. There is actually, because of the reduced intravascular volume, there is a significant redistribution of mesenteric circulation is happening. Next one. And if you look at the outcome, actually, there was no difference in ICU stain between this patient, but there was a trend in lowering lower ICU stay in terms of hours compared to in the intervention group compared to the control group. Next slide. So in conclusion, we were able to derive baseline cerebral and mesenteric saturation in both acyanotic and cyanotic, and there was a baseline MC difference which was negative in congenital heart surgery. So probably there is a redistribution is present, and cerebral desaturation events are detected early with the NIRS and better managed hemodynamics when we use the intervention protocol. The negative MC difference without any cerebral desaturation for CPD suggests that a significant redistribution of mesenteric circulation exists in these patients. Next. So site monitoring reveals flagrant redistribution occurring perioperatively, which we could not completely eliminate with our intervention protocol. So none of the patients developed any complication in terms of necrotizing enterocolitis or neurological sequelae, and total ICU stay in the intervention group was less, but it was not statistically significant. So the NIRS can be incorporated as a two-site monitor for pediatric cardiac surgery with the intervention protocol has shown better optimization of the intravascular volume and better oxygen supply and utilization, evidenced by lower cerebral desaturation, lower lactate level, and lower heart rate and higher filling pressure, and lower requirement for vasoactive anesthetic care. So limitation is a single center study, small sample size, heterogeneous group of patients. Only one frontal area was performed because we have only one monitor with a two channel, one we use for the cerebral monitoring, one we use for the mesenteric. The baseline values we could not establish in all patients because some patients were stressful and cooperative separation, parental separation anxiety, where only 40% of the patients we could actually get a baseline awake saturation. Thank you.
Thank you, Dr. Uni Krishna. Now I know that I should use one design probe and tailoring my plan according to an awake near baseline. And it also open up many new potential research in the future using the near probe. And now we will come with the Q&A session.
In fact, and again, I thank to all speakers for their very comprehensive and informative speeches. In fact, we have so many questions, but all of them have already been answered by the speakers in their speech. But I want to ask only one or two questions. One of them is for, I think, Dr. Unikrishnan or Dr. Kamlesh also can answer this question. Is NIRS value useful to know about the perfusion status of brain during hypothermia?
So the question is whether the NIRS value can be used during hypothermic perfusion technique. And this is the advantage of using NIRS cerebral oximetry because the temperature is not affecting its value. When we are seeing pulse oximeter and other monitor stop working, NIRS value is quite reliable even in a lower temperature where we are performing our values in a DHCA also, which we cool down to something around 20 degrees centigrade. So it is very much reliable and has to be used during hypothermic kind of a perfusion technique to monitor how much low flow the perfusionist will keep to adequately perfuse the tissue oxygenations.
Thank you. Thank you for your answer, Dr. Kamlesh.
So question from the Kevin Umani, is near monitoring a must for all the pediatric cardiac surgery case? I think Dr. Kamlesh has his own indication and he can talk more about this question too. Dr. Kamlesh.
So the question is whether the NIRS monitoring is required for all pediatric cardiac patients or not. Yes, answer is in one word is yes. Because most of the pediatric cardiac surgery, though it's a simple or a complex, there are a slight element of problem may happen during the simplest surgery of like ASD and VSTs. The second phase, which I want to answer, if there is a problem of financial or the problem about costing the probe, then we have to start with using in a specific scenario, a specific case load where it has to be used, like arch repair, neonatal complex surgeries, severely cyanotic patients. These are the absolute indications to use NIRS. So the cases where you are comfortable, you can use in all the cases.
Thank you, Dr. Kamlesh.
I want to clarify that Dr. Zach won't be able to with us in the Q&A session. If you have any questions for Dr. Zachary, you can ask from the email from Dr. Zachary. And there is a interesting question. Is there any limitations of cerebral oxygenation monitoring by NIRS in pediatric patients with cyanotic congenital heart disease and profound polystemia? Dr. Unikrishnan, we can't hear you. Sorry.
Only your audio is not working. No, not audible.
Maybe Dr. Kamlesh,
Yes. So
do you have any idea about this topic?
So we are using NIRS in recently in all cases, and there are definitely difference when you are using severely cyanotic. Especially what I have seen is if the hemoglobin or hemoglobin value is sometime we are seeing is 22 to 23 hemoglobin with a hematocrit value of around 70%. We are having a problem of getting baseline reading, as well as before going on bypass, we were having a problem of getting NIRS reading even after getting good signal. So yes, there is a problem of using NIRS in severely cyanotic, but as soon as we'll go on pump, there is some hemodilution, the NIRS value start coming. So one should not say that we cannot use in severely cyanotic. It has to be used, but preoperatively it is little bit problem of getting proper value.
Thank you, Dr. Kamlesh, for your answer. I think last question, we can take only one question because we have not more time. And as I said, most of the questions have answered in the speech of our speakers. What specific anesthetic agents or techniques can potentially affect the accuracy of reliability of NIRS readings during congenital cardiac surgery? Any anesthetic our anesthetic agents or anesthetic techniques we know all affect the NIRS readings. And is there any specific agent or any specific technique that we can say that it is more affect the NIRS reading or the NIRS reliability during congenital cardiac surgery?
Dr. Unni, you would like to answer if your audio is working? No. We are unable to hear you.
Still we can. Yes.
Not hear you.
Okay. Unni, we are not able to hear you. No.
So sorry. No, we can't hear you, Dr. Unikrishnan.
So according to my, there is no agent which directly affect the NIRS value, but it will affect when it affects the blood pressure, if affect the heart rate, if affect the overall cardiac or tissue perfusion. In that sense, yes, it will affect the NIRS value. Like if you are using propofol, if you are using thiopentone, suddenly there is a very sudden reduction in SVR while inducing the case. Then definitely it will directly affect the cerebral oximetry by overall reduction in cardiac output or overall reduction in cerebral perfusion. In that way, yes. But otherwise, I am not saying that any agent is having a direct effect on NIRS value.
Thank you. Thank you again for everyone for your very comprehensive and informative speech and for your answers. And unfortunately, we have to finish our webinar today.
Thank you so much.
And don't worry because we are available in the website, in the Facebook, and this webinar will be uploaded in the YouTube, and you can post your question over there, or you can send direct your question to our speaker today. Please visit, like, and follow us on these 3 platforms. And ASPA empowering through the education, we are a non-profit organization with a mission to foster the highest standard care for the pediatric in the Asia. So we seek your help to donate and help us in our cause. You can scan this to donate.
And last, I want to give some information about our last meetings. In 2025, there will be a workshop about perioperative pediatric life support during the ASPA 2025 in Kathmandu in Nepal. We have only 20 participants. We will have only 20 participants for this. Please scan and register earlier. And our next conference will be in 4th and 5th April of 2025 in Kathmandu, Nepal, with the collaboration of 24th Annual Conference of the Society of Anaesthesiologists of Nepal. And this conference will be the 25th anniversary of ASPA. Please visit our website for further information. And another information, the 15th International Congress of ASEAN Society of Cardiothoracic Anesthesia. And as a part of the pre-congress workshop, Innovators in Bleeding Management, there will be a clinical case computation, and the deadline is 13th of April 2025. Please scan QR code to find out more information about this meeting. And last announcement, this is the 9th World Congress of Pediatric Cardiology and Cardiac Surgery between 7 and 12 December 2025. It will be held in Hong Kong, China. If you want to take more information, please visit the website. And thank you all participants, all panelists, and our IT supports, Angela and Teddy, for your great supports. Have a nice weekend. Thank you to all of you.